Our second South West London CCG Governing Body meeting in public. Welcome to all of you who are here both as members of the governing body and some of the observers that we have from the local health watches. I won't go down the full list and call everyone out as we did that last time. I have apologies from Tonya Michaelidis. Are there any other apologies, Yvonne?
No.
Okay. So let's go straight into the meeting because we've got a huge amount on the agenda, lots of important things for us to work through. So I'll take us through at a gallop. If we go straight on to the declarations of interest, can I just get people to confirm that this is an accurate record of their interests? Are there any new interests that we need to add to the list, and are there any particular issues that people need to flag up to us because they cause a conflict with items we're discussing on the agenda? No?
No.
Okay, I'll take that as accurate. So if I can go then straight on to the minutes of the last meeting, which was on the 20th of May, I just want to go through and confirm that they're accurate. Now, because we've got a number of pages, I will just quickly whiz through page by page to give you an opportunity to call out if there are any particular issues. So page 1, page 2, Ray, that'll be Liz.
Yeah, sorry, it's Liz.
Yep.
Yeah. Sorry, I can't do them by pagination because I haven't got them in front of me, Andrew. So perhaps it's just simpler if I just take the couple of amendments I've got.
Yes. Yeah, why don't you call those out?
Thanks. The first one was in relation to, actually, it was page 12 of 115 because the numbering system was slightly different ones. And the question I was trying to ask was about the PPE for domiciliary nursing, not domiciliary care. And of course, the providers are different. And so the answer I was given was in relation to the local authority. But the question I was asking was in relation to nursing. And for example, our provider is a community interest company. Other providers are trusts. So
Okay,
if that could be amended.
Yeah, so Yvonne, if you could amend that, and maybe I could get someone to just pick up with you outside the meeting then.
Yes.
If you need more information then, because we hadn't quite captured the question, I'll get one of the team to contact you after the meeting and just talk you through the answer to that particular issue.
Or just drop me an email would be fine. Okay. Thanks.
Okay.
For speed, shall I just flag up the other point, which was in relation to the St George's cardiac care?
Sure.
And we've got an amended form of words on that, on what the issue was, which Susan has been cited on, and I'll send it to Ben Luscombe, if that's okay.
Okay.
Yeah.
Great.
Thanks.
Thank you very much, Liz. Then, well, let me just kind of go back. So I don't know if people all have access to the pages. Maybe assuming everyone's read through the minutes beforehand, is there anything else anyone wants to flag up to me about the totality of the minutes in terms of accuracy?
Yeah.
No? So can I then take those minutes as an accurate record of the meeting, taking into account Liz's amendments? Yes? Okay.
Yep.
There's no matters arising or actions particularly that have been flagged up to me. Anything in terms of matter arising that people feel I need to pay attention to before I move us on? No? Okay, good. Well, let's go straight into the chairs and accountable. Sorry, Liz.
There was a quick matter arising, which is in relation to Wandsworth Health Watch being sent a report in the action plan for cardiac care in relation to St George's. So I'll also put that in the email I sent to Ben.
Okay, fine. So that was under item 11, was it? Cardiac surgery?
It was the cardiac surgery item, yeah.
Okay, fine. Yeah, I'll let Ben pick that up with you then. Okay, shall I move us on then? Let's go straight on to the Chair and Accountable Officer reports. So you've had this in advance. You've got a written report from myself and Sarah. I'm not proposing that I read out my report to you. I'm taking it as read. And I'm assuming you've read Sarah's report as well. But Sarah, I think there might be one or two things you want to pull out. And I know there was something further you wanted to just report to people on the board. So shall I pass over to you?
Yeah, so firstly, it feels a bit late in the day that we're reporting on the ICS, which became a South West London ICS on the 1st of April. But I think it's right that we report it in here, and we are part of the partnership that is the integrated care system for South West London. And I think it's a really positive reflection on the very collaborative work that we've done over previous years with our partners across South West London, including our local authorities, providers, and the commissioners. So I think that's very positive, and we're taking forward the new ICS work. Obviously, COVID has impacted a little bit on what we would have been doing had we had we not had COVID. But I think the strength of the partnership during COVID has sort of rung through, really, particularly at a local level, where we've worked really strongly with some kind of community, local authority, primary care. So I think, and obviously with our acute providers as well, but I just thought it was worth flagging that. Moving Forward Together is there for you. It's just an update on where we are with the staffing restructure. I wasn't intending to say anything on that. And I thought it was worth mentioning the serology testing, which is that's where you find out whether or not you have had the test. It's a blood test, and we were asked to offer that to all of our staff, and we have been able to offer it by the 10th of July. Obviously, not everybody will take that up, because some people don't wish to have a blood test, or don't actually, or may already think they know they've had COVID and may not wish to avail themselves of that. Anyway, we have another week or so left to complete that. And just finally, the annual reports and accounts sign off, which has happened, and thank you to all of the finance team and also the auditors for their work on that, because I think that was a good piece of work where we were bringing together kind of 6 of the previous organisations. So I think that's well done to everyone involved in that. And then my final piece, which isn't on the list, was around improving healthcare together. And just to mention, and I know that governing body members are all aware, but just for everyone else's information, the decision around Epsom St Helier and location of those services of the Specialist Emergency Care Hospital will be made on Friday. The Improving Healthcare Together website shows how you can view that. It will be live streamed, so people can view it, and if anybody has any questions they wish to send in, all of the information is on the website about how you do that, and we're happy to take many forms of questions. So what I mean is, you can do it in writing, you can do it by email, I think you can ring in as well. So I just thought it was right for us to mention that today as well.
Thank you, Sarah. That's really helpful. And let me open it up to any questions or comments on the 2 reports. I'll just flag up that in my report it talks about the chair's action I was asked to take by Remuneration Committee, which is important for people to note. We have got the Remuneration Committee on the agenda later, and I'm assuming David will quickly cover that at that point. But let me open it up now to questions from the board. So Dagmar.
Hi, thanks, and good morning, everybody. Sarah, my question was around the serology testing, just trying to understand a little bit around what's the strategy, so what is the purpose, and then what are we doing with the results? Because obviously we all understand this is part of more research, really, in terms of understanding the epidemic. So we obviously have been working or trying to work with Tonya to see what does that mean for our collaboration with local authority as well. There was some discussion around some of our social care staff having serology offered in care homes. But to be completely honest, it does feel very loose. And I was just wondering, as South West London leaders, whether there's any chance of having a little bit more of a strategic approach to it.
So I will come back on that. So Dagmar, I could ask you the same thing, I think, because this is a national piece of work. It's not run or led by South West London. It's not even run or led by London. It is, and it's Public Health England, and the link, in my understanding, is through yourselves, Public Health Directors, and Public Health England. So sorry to throw that one back at you, but I think we're all in the same boat on that. My understanding of the reasoning behind the serology test, to understand, it is purely around information nationally on what the current state is to inform the spread of the disease, and I can understand why you would want to do that. But what it does not do is it does not impact on anything that we do or the way we work, because we do not yet know whether or not, if you have had COVID and you do have antibodies, whether or not that means that you cannot spread that anymore, or if you have any immunity to it. Therefore, all of the standard procedures that we currently are doing around PPE and everything else that we do still stand. So it makes absolutely no difference, is what I'm saying, is to our operational management, whether you have antibodies or not. The information is fed up nationally, and they are using that, I think, to track the disease. And I think that's the use of that serology testing, is my understanding.
Thanks, Sarah. So I think we're in a way a bit in the same boat, that we've also tried to just make a bit more sense and have a bit more agency on what is happening in South West London around this. And so I was just trying to work through whether within the discretion of working in a national system, there is anything else that we in South West London could do to give it a slightly more sort of strategic coherence. That was all that I was trying to think. And I mean, we, for example, have got the HIN. So are we wrapping it up into something a little bit more research, like are we sharing the results? What is our discussion around this in the ICS with other care settings, for example? And I'm raising it because I haven't got the answer, but I wanted to test out what the appetite.
We're really happy to work with you. I would just sort of flag that this is not a local South West London piece of work, that we do not hold the information that comes out of that, because we're not allowed to, because it would be identifiable. We don't hold that information. It does go through a different route. What I would suggest is there may be a discussion with Kevin Fenton, who is the Public Health England rep for London, and that, you know, I'd be happy to be involved in those discussions to see if there is more we can do. I'm not really sure what it is, to be honest, Dagmar, and I would take your advice on that. But I'm happy to be involved in any further discussions you'd like to have on that, and I know that Tonya would be as well.
Okay, thank you.
Thank you. Anything else that people wanted to raise or ask? I'm trying to monitor the comments as well. Liz is asking about, is South West London addressing the BAME recommendations in the Public Health England report? Sarah, did you want to just talk about the work that is being done on that?
So there's a number of streams of work on this. Actually, what I might do is ask Karen, because she's got, is Karen on? It might be better for Karen to do it. Yeah. Do you want to talk about the ICS work, but also the internal staff work? That would be great.
So we've been looking at this for some time, and you're right, Liz. The Public Health England looked at the initial research that was coming out and the findings, and recommended 7 actions in relation to equality, diversity and inclusion and health inequalities. And at South West London, as you'll be aware, South West London set equality, diversity and inclusion as a system-wide priority for action. And Millie Banerjee, who is the independent ICS chair, is leading a piece of work to develop a programme around that, which will cover both staff and local people. And that work is drafted, but is actually being discussed widely at the moment. So it'll be some time, I think, before we finalise the actual plan. So that's the South West London work, and yes, it does absolutely take into account the 7 recommendations that have been made, which are very wide. And in relation to the South West London CCG, we are doing the same. So we have begun to have conversations with our staff around equality, diversity and inclusion, and we'll spend the next few weeks having discussions with them and listening to their experiences. And then we will develop a South West London CCG programme that will address not only the 7 recommendations from Public Health England, but also the experiences of our staff in the CCG.
Thank you, Karen. That's really helpful to hear that. Anything else arising from the Chair and Accountable Officer reports? No? Okay. So let me move us on then to the first really substantial item on the agenda, which is a review of the community response to COVID. So Lucy's going to give us an overview, and then we're going to hear from each of the 6 boroughs.
Thank you, Chair. I'm going to assume that everyone can see the presentation because it's not being launched. As Andrew said, it's about the health and care.
Sorry, Lucy, so you want people to access that on their own devices?
That's what I've been told is the arrangement, that it's not being launched.
Okay. That's
so
fine.
I'll give people a moment.
Yeah, so if you just make sure you call it out in terms of which page you're on as we go through.
Yeah.
In my pack, they're numbered as 2, 3, 4. So I'm assuming everyone else can see that by number.
Yeah, so while people are finding it, I'll just do a brief introduction because we've described this as the health and care response. And I think looking back on the experience over the last 3 months, health and care services, we are divided by a common language. So I think when I've been talking to colleagues in health, and I use the term community, some people think I mean community nursing and therapy services. Other people within health think I mean the broader set of community health services, so primary care, community nursing and therapy services, mental health community services. And other people think that we mean health and care services that are delivered in the community. So I want to recognise at the front, this is not everything that we deliver in the community, but broadly covers the services that fell under the auspices of the community cell during the major incident response period. So that's community nursing and therapy services, specialist teams in support of care homes, end-of-life care, and the role of the voluntary sector. But I didn't want it to go unsaid that clearly primary care and social care were absolutely key, and I'm sure will be covered at different agendas and seminar focus sessions. And I did also want to say that although I'm presenting this is very much sort of standing on the shoulders of giant stuff. So I am presenting on behalf of South West London, but clearly the majority of the work that delivered this extraordinary level of transformation I'm going to talk about was delivered in boroughs and by borough teams, some of which were very small, some of which were really large and significant and part of integrated trusts, all coming together at that extraordinary moment in time. And I'm going to, having spoken about the work that went on and the achievements that were delivered, then in the last slide talk a little bit about building the recovery programmes going forward. So I'm moving on to the slide about community health services. And when I was reflecting on this this morning, it did occur to me that actually when I wrote these slides, it doesn't really do justice to the level of transformation that went on in community nursing and therapy services. So if I think back to the first week of the major incident, there was that moment in time where the isolation rules led to a significant reduction in staff available. Community nursing and therapy teams had to review their entire patient caseload and match patients to the services available. They had a Monday to Friday 9 to 5 service, which overnight became an 8 to 8 service, 7 days a week. And the overriding need to make sure that patients were cared safely, whether it was being transferred out of hospital or in their community setting, largely in patients' homes, was delivered at exceptional speed and with great professionalism by people coming together and working in partnership. So I outlined a small number of the things that happened here. So clearly there was, as well as staff having to work in different ways within their services, there were people who were redeployed to different services. So community services responded to the ask from acute, in particular the number of physios who went from working on MSK and community to working on intensive care units. Health visiting and school nurses stopped the work that they were doing on a daily basis and moved to higher priority areas including working in completely new fields as older people community health teams. As continuing healthcare was stood down as a process, discharge to assess, so people who were needing to transfer out of hospitals, instead of having their assessments in hospital, where these were delivered in community settings and safe packages of care delivered. There were a hugely accelerated development of integrated rapid response services, so delivering both proactive care and reactive support to vulnerable people in the communities. There were common pathways across South West London, enabling patients who move between settings but between boroughs to enable that to take effect in a smooth and streamlined way. There was a huge response to end-of-life care and care home work streams, which I'm going to come on and talk about. And while a lot of demand and capacity mapping had been done in hospitals previously, it was the first time that we tried to apply that to community and out-of-hospital settings in order to understand with a greater level of detail where we were going to see spikes in activity and how we would respond to that, and to give us some proactive ability to respond rather than just being reactive. So I'm going on to the next slide around in respect of care homes. And care homes, of course, have been the focus of a great attention during COVID, and I can be rightly very proud of the work that we did across South West London and within boroughs to support some of our most vulnerable residents in care homes, which was building on a huge amount of work that individual boroughs and we had done across South West London over the previous 2 to 3 years. So I've outlined some of the individual actions that were taken in support of care homes, but I think in some ways it underplays the team approach that happened both across South West London, in the way that there was a South West London care home support group, but also the work in individual boroughs where people did wrap around the care and by providing mutual aid for PPE, by doing infection control training, both face-to-face, with weekly seminars, with site visits, providing source materials, by providing staffing support into care homes to recognising their own problems with staff who were unwell or having to isolate, the rapid development of GP care home leadership, integrated teams and enhanced care home support. We, at a South West London level, we commissioned a bespoke bereavement and counselling support service for care home staff in and across South West London. We procured and delivered basic pulse oximeter, blood pressure monitor and thermometers to all care homes in South West London. And now, as a basis of new guidance that's come out in the last week, we're devising a training programme to ensure that all staff in care homes are fully supported on the restore and use methods for using the equipment. We got 96% of care homes supported onto NHS Net, and 90% of care homes using the National NHS Capacity Tracker tool, which enables us to see where there were spikes in infections, where there were shortages of staff, where PPE was needed. So this is a canter through, but I'm going to keep going. We're moving on to end-of-life care. Again, in end-of-life care, a huge amount of work done in boroughs, but a very strong coordinating role across South West London. And I think for me, end-of-life care is almost unique in the way that to effect really good end-of-life care, you need every part of the service, every part of every service to come together. So while the GP is important, so is social care, the voluntary sector, community nursing, hospital palliative care and hospices. So to pull all of that together across within a borough, but then across South West London, took leadership from the individual areas, and there was an enormous amount of enthusiasm and commitment right the way through the COVID process, which enabled all of these achievements to take place. So there was across the system a big focus on advanced care planning to ensure that appropriate and vulnerable people had the opportunity to describe and have documented their wishes for end of life. recognising that every bit of the system was under pressure, we also commissioned a new service from Marie Curie, who used their nurses who were isolating and unable to leave their home to do advanced care planning with people in care homes virtually, which assisted in some areas a tripling of the number of advanced care plans that were done in through the COVID period than had been achieved in the whole year before. We developed and delivered anticipatory medicine packs, so rescue packs for end-of-life care medicines for hospices and care homes that were available 24/7 from hospital hubs. Because our experience in end-of-life care in the past had been that some people went into hospital purely because it wasn't possible to get the drugs that they needed in the setting in the timescale that was required. There was specialist training through hospices for community nurses and care home staff in syringe drivers and death verification. There were webinars for GPs on COVID and end-of-life care, the very specific end-of-life care requirements. A professional helpline 24/7 across hospital and hospice services, an expert resource on the many processes associated with death management, a bidirectional DNA CPR between acute and community and primary care settings, and a comprehensive end-of-life care resource pack, which is now available in every borough. So the last area that I'm focusing on and want to celebrate is that of the voluntary sector. And I think that it has rightly been documented and celebrated, had the extraordinary response that we had from the voluntary sector. And I've just picked out a few of the areas here. The community hubs were set up in boroughs to coordinate the delivery of food packages to shielded residents. And that also included befriending services, delivery of medicine, walking of dogs, a whole series of other voluntary sector support. They played a significant role in support of rapid discharge to ensure patients had follow-up on contact and ongoing care, so they were a safety net for us. There has been a new referral pathway for vulnerable people without specific health needs requiring welfare checks and assessments, again a really valuable safety net for the system. The wellbeing calls, and now what we're calling a community response aligned to addressing health inequalities. How do we target this extraordinary effort that and achievement that has been made going forward? So lastly, how are we building this into recovery? There is a Care Close to Home group that is chaired by the Local Authority Chief Exec Ian Thomas from the Royal Borough of Kingston. And although we're still at very early stages, the work in that group has been about aligning organisations and teams who support communities to improve quality of life and reduce acute episodes. And it builds on the rapid transformation that was achieved through COVID. I think everyone agrees that we had about 10 years of transformation in the 10 weeks. So we're starting the next level of transformation from a new platform. What's our new level of ambition? That the partnership approach to community arrangements is all important. While the NHS has been in command and control, actually everything that is about delivering services out of hospital is partnership work. Only one part of the system is in command and control. So we have to be open, nimble, reflective, and genuinely open to that partnership approach to achieve the things we want to do for our most vulnerable residents. We've talked a little bit already about health inequalities. For across South West London, there are some significant populations that are very, very vulnerable: learning disabilities, care home residents, and then of course Dagmar's already referenced the work that we want to do with the BAME population out of the PHE report. We've recognised that there is a really significant issue about suppressed demand for children's services that we need to greater understand in order to put in some mitigating actions going over the summer and from September. And we want to ensure that the comprehensive approach we've had to end-of-life care planning and delivery continues in the way that it has been prioritised through COVID. And all of this is about delivering that optimal care close to home and making it a reality for all of our communities in all of the boroughs across South West London in the way that we have done so effectively through the COVID pandemic. I'm not sure if that was 10 minutes.
Thank you very much, Lisa. That was really helpful. And what's incredible is the amount of work that's been going on across so many different areas in the out of hospital response. And I know you've just pulled out a few highlights, and hopefully as we go through and hear from the 6 boroughs, we'll get some insights into some of the work that's been going on at place level as well. I'm going to wait to take questions until we've heard from each of the 6 boroughs, but I did just want to pick up one of the things that Liz had flagged up, which is in one of your slides, it talked about health visitors and school nurses being redeployed to do different tasks. So in terms of the services available for children, young people, and making sure that we're managing the risks, has there been any sort of strategic approach at South West London level on that, or has that been left to individual boroughs to work through?
So I wouldn't say left to, I would say there was a strategic approach in boroughs. So it was very clear, for example, that safeguarding leads and safeguarding teams continued to work, and in fact were enhanced in terms of their work, speaking for my own borough, through the COVID period. And I think so where school nurses were redeployed, some of those would have been into safeguarding and other protecting vulnerable children services. Health visiting, in particular, it's a significant workforce, and there were the similar issues about needing to shield and self-isolation for those staff, and some of them were set up to do telephone visits where they might have done physical visits in the past, and some of them who were able still to do face-to-face work did actually become older people's community nursing teams in support of care homes and other vulnerable residents. So I think on a borough-by-borough basis, there was a really detailed assessment of where the priority needs were, the staff that were available, and then matching one to the other. But certainly the support to safeguarding children was an absolute priority through the whole period.
Thank you, Lisa. That's really helpful. And Dagmar, let me just bring you in before I move us on to the borough updates.
Yeah, so very briefly, obviously, very briefly, thanks, Lucy. I wanted to just flag up that absolutely clear strategic approach on safeguarding. Where we have gotten issues immunizations, and that's, again, as a system, we've always struggled a bit, but had some really good areas. Sutton was always excelling, and in generally across the whole of London, including South West London, IMS uptake has dropped. There is still the perceived concern that healthcare settings aren't the healthiest settings, and so we are working very closely with NHS England, Public Health England, to think about alternative locations as well. So I just wanted to flag it here, not going into detail, but that is an area that we need to think about mop up.
Dagmar, can I just ask you a question? Because I think it's really important that the directors of public health, Pan South West London, absolutely feed into our recovery approach, and wanting to make sure that as part of the South West London recovery, we're overseeing where we're at with immunisations across the system. Are you clear from the directors of public health perspective how you are involved in our strategic approach to recovery, and do we need to do anything outside the meeting to link you in a bit better, because you've made a couple of really important contributions there?
At the moment, we have got in one representative who's Shannon, because we also are very keen that we are distributing the leadership functions. But I think it might be a good suggestion that we review a little bit how robust that is.
Okay.
Thank you.
Great. Really helpful. So let's go straight on then to hear from the individual boroughs on the same theme that Lucy's given us an overview of. I think it's Wandsworth first, according to my pack. Is that right, Nicola? Are you due to?
I think I am, which is amazing. Thank you to whoever thought that Wandsworth shouldn't always go last. Croydon cannot possibly always go first. Thank you. So my slides, I have to say, my slides are the same as Vassar's. So because of course our community response has got a lot in common across the LDU. So sorry, Vassar, if I'm just about to steal all of your thunder as well. really, this report, remember, refers to the community response. Of course, that encompasses many organisations, as Lucy was saying. So I'm going to talk really about community services, social care, voluntary sector, primary care, the CHC function, and of course CCG staff who were very involved in the whole response. And this story really is one of working beyond collaboration into partnership. And that description, I would say, particularly relates to the work done on discharge, where the approaches that we've been trying to implement for a long time came together, and people found that they could work together in a way that achieved results really quickly, and that was in fact the way they want to work. So whilst there might have been some perceived curtailment of freedom through the command and control approach, actually what it resulted in was people being able to work in the way that they wanted, which I think was a fantastic result to many people, patients' benefits. I'm just going to go through the kind of the first slide here, not in too much detail, but just to point out a few things. Shielding patients were really well supported by community, voluntary and primary care, with really important work done through the local authority community hub. And the identification of shielding patients wasn't really an efficient process, to be honest, in the way that it was driven from a national level. But once we locally understood who the people were that needed additional support, then it was there in abundance, including from the new social prescribing link workers from primary care networks, who'd really only been in post a few months when they were called upon to support hundreds of patients remotely, which was never what was anticipated from this service, of course, but it did happen. And in fact, in Wandsworth, 1,966 people from the vulnerable patient lists were contacted up to the end of May through that route alone. There was a bit of an expectation, I think, that community services might be overwhelmed when we went into this pandemic, but actually the lived experience for some people was that it didn't really materialise, partly due to the extensive rapid planning and shift in staff, but also because of an unpredicted, I think, response from families and carers. And it might be that families during lockdown had more time to attend to vulnerable relatives. For example, more people were able to self-administer insulin injections with support from their family members, who perhaps were more available during lockdown. People were declining services because they preferred not to have healthcare staff visiting, so they managed their own dressings and the like. So I think the expected real strain on services perhaps didn't materialise, which is a really good thing. Also to say the development of primary care networks was massively accelerated during this period. The primary care networks and the GP Federation response was very collaborative and constructive. We had hot site provision developed relatively efficiently, with quite a low level of additional expenditure, and Wandsworth developed early on a mobile pulse oximetry service which allowed rapid and early implementation of the London respiratory guidance, which meant that people could be monitored at home safely, which was really important. So on to the next slide for Wandsworth. So the key really to the next stage is for community services, I think, to align with PCNs, and I think this is mission critical to further development of a local integration of pathways and services, building on what's happened to really make that possible and embed that now, but it does require a reconfiguration. Discharge to assess pathways would ideally be maintained in their current really efficient state. I think that could be quite challenging depending on the legislative situation. Care home support, clinical support well catered for in Wandsworth, but nevertheless there's more that needs to be done, and particularly around care home staff and how they are able to work in care homes in partnership with other agencies. And then finally, I think there's a significant piece of work that we have to do to address the pent-up unmet need and reinstate proactive care where we can. I think we need to prioritise that and aim to focus this on people who are likely to be disproportionately affected by contracting COVID in the future. So it's part of the preparation for living with COVID. people at high risk could be offered the opportunity now to understand their risk and become COVID fit. And people with those risks that are related to poor outcomes should be prioritised. So people with diabetes and those from Black, Asian and minority ethnic communities. So that's what we're going to be trying to work for in the next stage.
Thank you, Nicola. That's really helpful. And I guess just a question from me about, I think the slides on lessons learned and what we need to do next is really useful. And I can see that each borough has taken that approach in their presentation. So is that information feeding up into the South West London primary care and community cells? And is that then informing our strategy as a system? I'm assuming that we're taking this and feeding it up, but just checking that that's the process.
Yeah, and I think it's a two-way, of course. So the kind of, we've got borough clinical leadership in primary care who are very embedded in what's going on at borough level, and they meet together in our primary care clinical cell supported by their local borough managers. And then there's an integration between the community services integration, so Lucy's work stream, and the primary care cell, which will be developing into this recovery architecture, which that meeting of those two groups is really, really important. Absolutely.
Okay, thanks, really helpful. Let's go straight on to Vasa for Merton. So it is a duplication of the slides, but I'm sure you want to give a Merton perspective on that.
Yes, the same slides, but the narrative slightly nuanced at various places. Yes, I want to highlight the voluntary sector and the social prescriber partnership dealing with shielded patients was a very good response in Merton, and it's evidence of our foresight in our LDU, where we invested into this before COVID, and we were ready to act. James has really been good. He has seen the benefits of our rapid discharges with continuing healthcare, with no financial constraint in discharging people into the community. And I think that the lessons we learned on how quickly people can be discharged and the problems settled thereafter, I think it's important to learn that lesson and not to go back to the days of slowing discharges from hospital. PCNs really stepped up at times. They mobilized themselves before they got approval to launch projects. So I get an email saying project is approved, and within half an hour I am told project is now running, which is really brilliant. We set up our first hot site in the east of the borough at Whiteway, followed by a few weeks later in the west of the borough. Our home visiting service, our rapid response service never ran out of capacity. This is really good evidence of how staff are deployed, but also how CLCH staff worked beyond their normal job description. No one came back and told me this is not my normal competency, I don't have the capacity. People stepped up, and I think we need to acknowledge the fact that traditionally healthcare workers are told always work within your competency, all work wear the badge you wear and do the job what the badge tells you. But here people forgot their badges and they stepped up. I think we need to thank them for that. I think we need to be focused on the BAME community's vulnerability, pre-COVID vulnerability, but also we mustn't forget our older people who not only live in care homes, but who also live isolated lives in their own homes, and we really need to not to miss the trick on that. Otherwise, we will learn the lessons of lonely people living alone in the next wave. Thanks, Dagmar, for talking about the IMSS, but I think we need to look at cervical smears and other screening programs which have also been stalled. And once again, the more vulnerable people who previously didn't turn up for smears are now more likely not to turn up again. So we really need to be more proactive. And I take the view what Nicola was outlining there. We have to have pre-rehabilitation for our vulnerable people, which also includes older people. The BAME community, yes, suffered from COVID, but so did older people. So I think we need to pre-rehabilitate our older population, but also a new cohort of people, the survivors of COVID, who have survived COVID, but have damaged lungs, damaged hearts, damaged pancreas, damaged kidneys, etc., etc. And I think we really need to now look at that cohort and see what is the best re-ablement we can offer them, and that is important when we restart services like Harry, that we need to focus on that cohort, which did not receive the traditional discharge 6-week follow-up CT scan or chest X-ray at times because of the acute phase of COVID. And I think we need to go after those people in a polite way, not go after them in a bad way. Find them and bring them in and rehabilitate them.
So that's incredibly helpful and insightful. I think two critical things that you picked up. One is the targeted work for those more at risk in terms of management of long-term conditions and getting them in the best possible shape to protect them from future COVID. And I know that's something that's being looked at in the South West London primary care cell as well. And then you particularly referenced COVID aftercare, where we are or we have set up a South West London work stream to look at that. So it's really important that that connects in with the work that's being done on a borough by borough basis. And COVID aftercare is an example of an area that cuts across all different areas of our health and care landscape. So you need acute specialist input, you need community rehabilitation, there's a role for primary care and a big role for mental health in that. So I'm pleased we've kicked off a work stream. I think it's really important that that is connecting into what you're doing on a borough by borough basis as well.
Andrew, and teenage and school children, I think we need to focus on how this has affected their mental health, not purely the education or nutrition, but also the mental health consequences too.
I totally agree with you, Vasa. And what I do know in my lead role on the children and young people's mental health work, Pan South West London, is we have done quite a bit of work around that. But obviously those children who are at schools that are part of our Trailblazer programme have had more support than others, although we have rolled out online support and therapy for all children and young people in South West London. So that was one of the actions we took as part of COVID. But I think there's a lot more to be done, and there'll be a lot more to be done going forward for sure. James, you had your hand up. So as Managing Director of Merton Wandsworth, you probably want to come in there before I move us on to Sutton.
Yeah, I mean, what I would just build on in terms of the points that both Nicola and Vassam made around the prehabilitation and getting communities COVID fit and addressing modifiable risk factors is that I think the partnerships we built at borough level with the voluntary and community sector, with our local authority partners during this, are actually integral to how that's done, because actually we've been working on long-term condition management with these communities and in the boroughs for quite a long time. And actually I think that what's really important is that we do that work with communities in a way that works for them, that uses the strength and resilience that we've got within communities and some of the established and trusted channels within those communities, and also really proactively addresses issues like the digital divide and the risk of digital exclusion, actually, which when we are running so many services on a virtual by default is a really significant risk. So I think there's a real opportunity now to take forward some of our visions in all the 6 boroughs around that partnership and make it really concrete over the next 2 to 3 months in terms of modifying some of those risk factors and making a real impact within communities.
Thank you, James. That's really helpful, and I think we'd all totally agree with you on that. So hang on, I've got a couple of hands. I'm not going to, let me just see. That one of those was yours, James. I'm struggling to get on to see who else it is. What I'm trying to do is largely defer questions to the end, but Dagmar, you're probably wanting to come in from a Merton perspective, so I'll let you do that.
Well, I am very brief. Sorry for barging in again, but for me, one thing, and again, as South West London as a system, really important is that during command and control, we have reverted a bit in terms of quite a deficit model. We labelled everybody as vulnerable, and we created actually quite a lot of potential dependency with our shielding. I think it is high time now to go back and say our communities aren't just vulnerable people with deficits, they're full of strengths, and go back to really do the co-production, the engagement and the strength-based approach. So for prehabilitation, COVID fitness and recovery, for me, that is really important as a strategic sort of frame, and I just wanted to get that in.
Thank you, Dagmar. Really helpful. So let's go on to Sutton. Jeff, I think you're going to present this.
Okay, Andrew, thank you for that. just find this section really useful to hear about the good practice that is going on in other boroughs, and we work hard on supporting our own boroughs to implement excellent integrated care, but actually we still got more to learn and listen to from the other boroughs, and I think that's really helpful to do so. Lucy has been so complete in some ways in some of the things that are affecting all our boroughs across southwest London, but I'm just going to highlight 2 or 3 areas that particularly relate to Sutton. We previously had integrated our health and care services into a team called Sutton Health and Care, but what COVID has done is helped to accelerate the way that we have integrated working in Sutton. We have 4 PCNs, 4 primary care networks, and what we have done is wrapped around those a community response team that has further developed the integrated patterns that support each PCN, and each of those PCNs have then taken further leadership in a particular area of coordinated care that then supports the other 3 PCNs that we have in Sutton, and it's been a really good model for helping to develop and integrate what we're doing, and that's around our care homes, our nursing teams, our palliative care work, the rehabilitation services that are in the community, and then our health and wellbeing teams and voluntary sector. Particularly wanted to sort of highlight that we've started a health and wellbeing team for the elderly, and that is, I think, a recognition that we want to be proactive with that group going forward. It is the next step of work. The second area I wanted to highlight was around the voluntary sector and their large-scale response and how we have really been able to, our residents have benefited from that. The figure on our graph is, of course, 3,000 residents have benefited from food and provisions. But not only that, there's been other forms of support, and that may be through social prescribing and through the delivery of our medicines. So many of the voluntary sector support organisations have made sure that medicines are flowing from our pharmacies to those with greatest need. The second area was around our home care. So Sutton has the second highest number of homes for a borough in London. We have 76. Second only to Croydon, and we identified early that this was going to be an important area for us to address the health and care and safety of all our mobile and non-mobile residents in nursing homes, learning disability homes and mental health homes. So we developed a jointly chaired provider board that established some of the integrated strategic and operational things that needed to work to support our homes within the borough. So all our homes have had the opportunity for infection prevention training. They all now have direct clinical support, and that clinical support has been formalised in terms of it being named, but also that hot off the press was an appointment of a direct home care support lead that can actually then support those that are providing the clinical support in our homes across the borough, and we're really excited about that piece of work. We've developed a Sutton Restoration Board so that we can locally input and provide a restoration across our system, particularly around things like planned care and urgent and emergency care work. And we've integrated our discharge to access pathways, making sure that the hospital teams and the community teams are working really well together. And that has reduced the time taken to access such services, but also helped to reduce the time for discharges from hospital into the community setting. And I lastly just want to mention around the BMAE response that has come out of this meeting in other parts of the meeting, but Sutton has also wanted to make sure that there is a local response to support and coordinate across the southwest London. And so we have a Sutton Fairness Commission and Race Equality Task Force that is undertaking that for our residents. Thank you, Andrew.
Thank you, Jeff. Just checking I'm unmuted. Yes, good. Thank you, Jeff. That was really helpful. Shall I move us straight on to Kingston? Naz, I think you're going to talk through this.
Yeah, I'll talk through. Thanks a lot. I've got poor internet connection, so just bear with me. Just coming back to Lucy's presentation, just to let you know that we've actually gone across all our we've got complete coverage on our care homes, worked very closely with the PCN CDs as well as the practices. And following on from that, we've got a very good uptake with advanced care plans in Kingston, utilising the service of the Marie Curie workforce to try and help improve the uptake of CMC records. We've done a piece of work with the local authority and our GP colleagues, plus the community services, looking at the unmet needs and unintended consequences and the learning that we can get from COVID. We've been using data to try and support this analysis, and we should be having the outputs over the course of the next week or so. We've been looking at the health inequalities, the missed opportunities around the diagnosis, also mental health and the unintended consequences of COVID itself on long-term conditions. We've been looking at what Jeff was talking about around the frail elderly and also complex patients in the community, looking at the transformation work that's occurred across Kingston and Richmond, and learning from the efficiencies that have been implemented during this phase. There's been a task and finish group which has been established to represent system partners, and we're developing that programme of work going forward. We've got and had a significantly enhanced support from the voluntary sector to the population, and we're really thankful to the local authority for coordinating this piece of work. As a specific, we're exploring a proposal around cardiology in the community and a new way of working with our cardiology colleagues in secondary care, to try and look at ways of being able to help support them in IPC measures, and also supporting in the new ways of working around virtual by default. These are still at early stages, but obviously as the outputs occur, then we'll be sharing them with you as well. So that's what I really wanted to touch upon, Andrew. Thanks.
Thanks, Naz. That was really helpful. Sorry, I've got a slight lag with my computer as well. I mean, I think as we hear from each borough, it's really incredibly impressive how much people have been doing, and it's a similar story from each place. And it sounds like all the work that has been done on a place basis in terms of joint work between health and the local authorities and the voluntary sector and communities really bore fruit during COVID, and we'd put those key building blocks in place which were essential for our response, and it's really encouraging to hear that. Let's go straight on then to Richmond. So Patrick, I'll get you to take over.
Thanks, Andrew, and thanks again to Lucy for that fab summary, just indicating the scope of the work that has been going on. Clearly, Naz and I work very closely. Kingston and Richmond have become closer as a consequence of the work that's going on. So starting off, really, our clinical and managerial leads have worked really closely with the local authority around the care homes work. So that in addition to meeting the 5 care home requirements, we've actually been developing enhanced input to our LD homes as well, after early concerns about higher than expected mortality there. So that's been very positive. Moving on then to advanced care planning, we've continued to actively promote this. Clearly, this was something that was being promoted before COVID, but certainly been accelerated as a consequence. We've reached 68% coverage of all our care home residents, and more widely outside of the care homes, we've seen a 50% increase in the use of CMCs since the end of January. So that's positive, but definitely not resting on our laurels, because there are still people who haven't got those in place. We've adapted our local physio service provision, working with our community provider, and within that, we've been helping them to accommodate the new referral assessment service that we've managed to get set up at Kingston Hospital, which we have high hopes for. Pre-COVID, we were already engaged in a significant demand capacity piece of work around Kingston Hospital, and that's inevitably taken on a new impetus and a new focus, I think. I think the Trust maybe have seen opportunities to help them out of COVID, which has helped us hugely. And that's now supporting patient pathway development, incorporating changes in the way that we use technology to achieve that. Linking into the wider community, we've convened our first health and wellbeing board. We've had our first PPG meeting. We've got our community integrated group meeting tomorrow. So those are the first meetings we've had since COVID with them. And we've led the discussion there about the importance of maintaining the focus on inequalities during the transition of services, and especially the emerging issue of digital inequalities. We referenced earlier on children and young people and some of the value with that. Clearly, you know, with digital solutions for supporting children and young people, we need to really critically appraise whether some of our digital solutions for that population are necessarily that appropriate, if that is the population who struggled with online learning. So we maybe really do need to be aware of that. Through our weekly webinars, which we've continued with, we've explained the responsibility of senior partners in the practices to formally risk assess their staff, particularly with the BMA focus, obviously. We're accelerating the expert patient model, promoting South West London LTC offering, expanding and promoting the roles of social prescribers within that. Naz referenced the long-term conditions, so Richmond clinical leads are leading that Kingston and Richmond transformation work across partner organisation with a task and finish group focusing on proactive identification and intervention and improving the connectivity between partners, which obviously is one of the key features of this. There's a particular focus within that work on anxiety and low-level mental health issues and their impact on the use of services and their capacity to self-care again. So that was a feature that we'd identified early in the demand capacity work around Kingston Hospital, and we just want to make sure that that is retained because it's such an important part of the picture. I think that's all I want to say, Andrew.
Thank you, Patrick. That's really helpful. A really good overview again of all that's going on in Richmond. Just to flag up, I'm noting all the comments in the chat. We might not be able to respond to all of them in the course of the meeting, but we will make sure that will be picked up by the team. And if we don't address them in the meeting, I'll make sure that someone picks up those issues and gives a response outside of the context of this board. What I'm going to do is move us straight on to Croydon, and then we'll have a little bit of time at the end of this item just to take general questions and respond to those. So Agnello, on to Croydon.
You've got Richmond first. You've got Richmond, I think, first.
No, Patrick's just done Richmond.
Oh, okay.
I was too quiet, sorry.
Okay, so Croydon, and obviously last but not least, we did have the hit the hardest in terms of South West London relating to COVID, and we responded really well. And I think what I wanted to highlight here is the impact of leadership, not just in terms of managerial leadership, but also clinical leadership, working with managers. The One Croydon partnership was critical to this, which was underpinning a lot of the response that we had. GPs working with the hospital, working with the local authority, the voluntary sector, mental health trust, all coming together in different ways to ensure that we could use staff differently, we could make decisions really quickly, and that was a really good learning point, that when we had to make decisions, they were done quickly and effectively. One part I really wanted to highlight was the clinical leadership in the borough team, who were, in terms of the clinical SROs and SMEs, who were repurposed from facing the health and care plan to facing what needed to be done in the pandemic. And so each one of them had specific areas that they led on, from primary care and the urgent emergency care changes that we needed to have, proactive and preventative care, shielded patients, working with local authorities and the voluntary sector. Another one of them working on the out of hospital and care homes and the death pathway, working with coroners, and also actually working at the front line as a clinician in the rapid response service. Another clinician working on the end of life pathway, another on the mental health aspect of of the whole response, and another on the planned care and the cancer pathways. One of the things that was a hallmark of what we did in Croydon, it was to work as a whole community, and our weekly calls, which was attended by over 200 people at a time, included not only GPs and practices, but also pharmacists and dentists, and the local medical committee, dental committee, local pharmaceutical committee. And we had clinicians on the front line looking after COVID patients from the hospital, also feeding back what some of the clinical issues were at that particular time in hospital, but also what to expect when patients were discharged. So there was a lot of learning, collective learning across the whole piece. The issues relating to inequalities in the BAME population have been ably picked up by the local strategic partnership, which is chaired by the leader of the council, and that is feeding into what's happening at the ICS level as well. But there will be a local nuanced element to that in terms of Croydon, and also being picked up by the Health and Wellbeing Board, and we've got a workshop on that today. So I think in terms of what we've learned is that the underlying partnerships were key. These are things that we want to carry on working on. The integrated care networks built around populations of around 50,000 are critical in terms of moving forward, and that's already happening with one of the networks actually moving on from just being an integrated care network to one that has much more integration with social care, social prescribing, mental health, and the teams from the hospital as well, and the PCNs. So it is becoming a truly multidisciplinary team, and today we launch a diabetes service as well, which is going to be in a partnership between the hospital and the community. Primary care networks are evolving, probably not as evolved as in other parts of South West London, but they are evolving, and I think this is something that we need to nurture going forward. As mentioned already, the voluntary sector came into its own, and it's just been unbelievable in terms of the response, in terms of supporting our citizens in Croydon at home, which was just, on a scale of 1 to 100, it's probably 200. And certainly from my own patients, getting first-hand feedback on how they were supported, the only descriptor is it's amazing. And I think people stepped up to volunteer. The voluntary sector was overwhelmed with people coming forward. And as part of the partnership of organisations moving forward, it puts us in a good stead. In terms of the hospital and discharge, the local authority working together with health has developed new and better pathways in terms of discharge to assess, rapid response teams working much more effectively in the community, supporting people in early discharge. Our pilot telehealth with the Airedale system came into its own with care homes in terms of managing people at home. We've learned a lot in terms of where we've come from and able to respond rapidly when things changed, and part of that is because of the relationships in terms of being able to pick up a phone and being able to mobilize things. Development of the care, the hotels for the homeless happened over a weekend. Thinking about expanding facilities for discharging patients in terms of nursing homes developed very quickly, and I think it's the hallmark of the relationships that this puts us in a good position going forward. It's already been mentioned about the digital response, supporting young people, but also adults in terms of mental health, which was greatly expanded, supporting our maternity needs virtually as well. And it's really about where do we go from here now in terms of how we work more virtually by default, how the infrastructure for digital actually it gets upgraded and moving forward at the pace that we need, and becomes more integrated as we move into the integrated care network. So a lot of learning during this period, which was founded on the relationships that we had before, but it was the clinical and professional engagement at every level in every organisation, working with managers, that really was the key to success going forward. And so the integration agenda is really truly moving forward at a pace now, with every looking in terms of what we've done and how successful we've been on some of the things we know so well. So learning trajectory is really going to be helpful moving us forward, and learning from the other boroughs is going to fall in terms of adapting as well. And as we start moving into the new urgent emergency care response, until things are going to get quite exciting. So I'll stop there.
Thank you, Agnello. That's really helpful, and a really comprehensive overview of all the things that have been going on in Croydon. Shall I open it up now to questions? We've probably got about 5 minutes if people did have things they wanted to raise or ask. So I've got Pippa and Susan, so I'll come to Pippa first and then Susan.
Okay, thanks, Andrew. Really helpful from everybody. Thank you. So good to hear about the out of hospital focus on this piece, and there's a huge amount of work that's gone on, and thank you to everybody who's been part of that. It's also very clear, listening to everybody, how critical this is to our recovery, and we heard very clearly the link between the community and the primary care cell and how strong that is. It would be, so I've got a couple of questions. It'd be really helpful, I'm sure it's happening, to get confirmation that the community cell is linking as closely with the acute cell, because many of the strategies that were highlighted had links between acute and discharges and various other things. So that's the first question. Second question is a slightly adapted question to my original thoughts. Lucy, you've talked about a lot of the sort of strategic work that's going on, and I wondered if there were clear, if we were clear what the kind of the issues were that had the biggest impact, and the risks to those in our recovery. So, and Bruno put a really helpful one on the chat box around community. If that's the bit that's worked really well now, and going forward, if that might change, will that have an impact on how we're going to manage it? That's just one of them. And the other point that James and someone else mentioned, I can't remember, I apologise, but I absolutely feel really strongly virtual by default is absolutely the huge change that we've introduced here. And I know in other parts of the country where I do some work, there's some work going on with the providers around evaluating that, because the critical issue is the effectiveness of that for the individual, the experience of that, and the safety netting of people who can't get access to it, and having a strategy around that covers us going forward across South West London might be something we need to think about. Okay, so I think there are three parts to that. The first was the link between the acute cell and community cell, I think particularly in relation to discharges safely into the community. I think that's largely been dealt with by the community cell with some conversations with the acute cell, but it's not been the big focus for the acute cell. So you might be able to answer that one, Lucy, and then you can answer specifically the question that Pippa asked of you. The final question around digital and virtual by default, I think there's a number of different aspects to that. I mean, there's a big health inequalities angle and making sure we apply that lens to any of the changes, but particularly to something like virtual by default. I know we are thinking about that, but I don't know, Karen, it may be there's something for you to add in answer to that. And I think one of the things you pick up there, Pippa, that I've had conversations with at the London level and in South West London, is around the blanket nature of some of these changes and doing things at scale. So a big shift to virtual by default,
but allowing still an element of personalisation. And I think one of the things we have to tackle next is what's our approach to personalisation pan South West London, to make sure that any at-scale measures we adopt have the ability to be adapted to particular communities or individuals. So I think that's a helpful challenge. So Lucy, let me come to you, and then Karen, if there's anything further you wanted to say, I'll let you come in.
Okay, thank you, Andrew. So yes, if I describe the evolving architecture for recovery, I think Pippa, you're exactly right. It is still work that we are developing, and there have been conversations even this week that are looking at the many different programs of work that we've had under the community cell, some of which have been, as I started at the very beginning, describing the different types of services and what we mean by community, how we make sure that absolutely all of those are picked up and taken forward into the recovery architecture, how they relate both to the specific primary care work streams, and then where appropriate that there are acute members probably of the work streams that are around primary and community interface, rapid response, proactive care, and timely discharge. I'd also pick up long-term conditions in that. So we've had a little bit about the work in trying to make sure that there's COVID, really strong rehabilitation pathways post-COVID, but that applies to a whole set of long-term conditions. We've always had strong borough programmes. We've also had South West London programmes, and it's now making sure that that's tied into the recovery programme as well, and it brings together all of that the acute, the primary care, the community elements going forward. So I think you raise a really good point. The fact that it is still evolving is because it is very complex, not just about making sure that we pick the best from recovery, but we don't lose all the good work that was going on in the background before. So your question about impact and risk, I think there are three things that had a really good impact. So had the biggest impact in those initial phases and the development of our response to the COVID outbreak. The first one has been well emphasised by others, particularly Agnello, and its relationships, because those relationships were key to people having confidence to behave in a flexible way, as was required, whether it was about changing role or extending role. It provided that the context of trust in which people could do things differently, and I think that's as we've heard, every borough has done things differently, which is not just okay, it's really important, because we have different populations and different providers, and we have to evolve things differently, and you need trust in order to do that. But also it allowed the innovation to flourish. So people sometimes seek permission to do the right thing, and people started getting on with it rather than waiting for there to be layers of governance. So I think those were the three things. So that's in relationships. The other things were data sharing. We were able to share data in a way that we are not traditionally able to do, and that had a massive impact in speeding things up. And I think that will be quite interesting how we think about that going forward. And then finally, I'd say the funding. So particularly around discharge, to assess the funding streams around continuing healthcare were suspended, so that it became a very, very smooth process to manage people's complex care in the community through a single health budget. So in terms of the risks going forward, I think the bit about relationships, we are in a really strong place because we had this integrated care approach, and it's fantastic to hear from Agnello where Croydon are at one end of the spectrum, and obviously there's a paper later on the agenda that outlines how strong their network arrangements are, but every borough is in some part of that, some part of that development, and we're all developing differently, and that's really good. But I think that I feel confident around those developments because of the way everyone is approaching the learning and how we want to take forward that next level of ambition. We all recognise it's going to be difficult. The financial position for both local authorities and the NHS will be different going forward. So, but we have built really strong relationships that we want to continue going forward. The data sharing, I don't know what the national guidance will be, but I think we have to, even before the relaxation of some of the data sharing legislation came into force, there were ways that we could share data that were safe, and people often didn't because they were scared of getting it wrong. There was a real anxiety about it, and I think that we could put some emphasis going forward into doing the right thing for patient care and residents, and being very clear about how we do that within the legislation, assuming it is put back in place. And lastly, the funding issue around continuing healthcare and discharge. There are some regional conversations going on that I was involved in yesterday that suggest that if continuing healthcare comes back, it will look very different. So I think that we're not the only people to reflect that the changing of the funding arrangements for people with complex care in a community setting. That changing of those funding streams made a significant difference. There's a very, very low number of patients who, with a long length of stay in hospital at the moment, who could have been discharged, very different to the way it was pre-COVID. And so I'm hopeful that the risk of that going back and ending up with lots of stranded patients again won't be the case.
Thank you, Lucy. Thank you.
Thank you, Lucy. And the second part of the response was, I'm coming to you, Karen. I'm hoping that you might be able to pick up some of the comments that have gone on in the chat field as well in your response from the perspective both as digital lead and leading on EDI, because I think it's probably pertinent to your role. And then I'll take the one final question from Susan, and then I need to move us on.
So I can't actually see the questions at the moment because I've got a problem with my machine, but I'll
a lot of comments about virtual by default and the impact that might have on particular groups and people, I think.
So I suppose what I would say is we went to virtual by default, didn't we, because of the need to lock down the country, and we saw some really excellent acceleration of digital because of that, and we have seen some impact of that. And I think there is a recognition at both London level and certainly across South West London organisations that one size does not fit all for a variety of different reasons. And we are going through the recovery. We'll be working with each of the programmes to identify the digitalisation that is required, but to put it in place in a way that works with the range of communities that we work with. So for some, going completely digital is great, and others it just doesn't work, and we need to work that through. And Charlotte may want to say something. So as part of recovery, we've also looked at how do we get the local people and patient voice into what we do, and particularly help us understand their experiences of some of the things that we have implemented during COVID. So there'll be a piece of work that we do, and there's already some emerging work anyway, and some emerging things coming through, and some emerging feedback on what has worked and what hasn't worked. So we don't want to exacerbate health inequalities, and we need to make sure that the digital solutions that we put in place don't do that. And also it may be that we need different avenues and not just a digital response, but we'll have to work through that through all the recovery programs as we move forward. But it will be very much shaped by the views of local people, and that's the work that Charlotte and her team will help us with as we go forward.
Thank you, Karen. Charlotte, did you want to say anything very quickly, or shall I move on to Susan's question? You might be having trouble unmuting, Charlotte, and I assume that you're going to pick that up anyway. Let me come on to Susan. You had a question. I'm going to make this the last one on this topic because we've got to move on to the other items on the agenda, but you flagged up early on, Susan, you had a question.
Yes, it was really picking up on some of the challenges about making some of this positive transformation sustainable. And it isn't particularly it isn't just about community services, but I'm exhausted to think about the energy and passion and drive that people have put into this, whether from the voluntary sector or from senior management clinicians, and the sustainability of that workforce to maintain that pace is going to have to be supported, isn't it? And I just wondered at a future date we might have some feedback on how we're working together collectively to support our people, because what they have been able to do is fantastic, but I don't see how we can maintain that level of pace, really.
Thank you. Karen, do you want to, it might lead quite neatly into the next item on the agenda, which is an update on recovery and how we are going to take some of the lessons learned during the response and some of the good practice and build on that, resource it and accelerate it. So shall I just lead into you, and you can pick up what Susan said as part of your update on recovery.
Okay, so I'm on page 51 of the pack, just in case anyone's lost their page. And I suppose, I mean, it's amazing, isn't it, when you hear, you know, the presentation that Lucy gave and then the presentation that clinical chairs have given on the amazing work that has happened. And that's not the full health and social care response either. So so we have, as you know, last time we came and talked to you, I presented the first phase of COVID, which is a summary of what everybody's just been talking about. Recovery is about moving beyond the initial pressure phase of COVID, because we've seen that ease in London, and move into what's called the second phase, and shorthanded as recovery a lot of the time. And to make sure that all the things we've just discussed, that we safely bring patients that do not have COVID back into services. We've mentioned some of those things already, but actually we pay full attention to infection prevention and control as the guiding principle as we bring patients safely back into health and care services. That we lock in, and this was a feature in most clinical chairs presentation, that we lock in those benefits. We've seen tremendous change and transformation over the last few weeks, and we need to make sure that as much as we can, the real benefits that we've seen from COVID are locked in. But also we need to also make sure that through the subsequent phases of COVID, actually, that we retain our ability to respond quickly and repurpose what we do should we see a surge in capacity or a second wave of COVID. So as we move forward into recovery, they are the things that are focusing us. And the idea of the presentation today is to just share with you the emerging thinking of recovery across South West London. So if you move on to a slide or page 55, as we set off and began to think about recovery, we were mindful of a number of things, and we wrote those into the first slide on page 3 of my presentation, but 56 in your packs. So we want to make sure that we respond well to COVID and we recover, but it's within a South West London context. And that South West London context is that collectively health and care organisations across South West London set a 5-year plan and a vision for people in local boroughs to start well, live well and age well. And we need to keep that and hold that as we move forward. We obviously want to make sure that we continue to innovate and ensure services are safe, because we need to bring patients back, as I've just said. And we know, and command and control has been spoken about throughout the meeting, we know that has particular behaviours and particular needs, but actually we have a commitment to working with partners at borough level and with local authorities to make sure that all the fantastic work that you've just heard clinical leads describe continue to happen at South West London level, regardless of whether we're in command and control or not. So we are committed to doing that. And it has to deliver not only the response that we need to put in place for COVID, but also think about the next 2 years of our 5-year plan, which has been changed by the work that we've been doing over the last 10 weeks or so. And digital is a really good example of that. And some of the care home work, etc., that Lucy talked about was also in our plans that actually has been accelerated. And Susan, your point, we need to make sure that we support our staff through and beyond recovery, because our stated aim across South West London was to make South West London a great place to work. And at the moment, we'll be shifting our focus to health and wellbeing of staff to make sure they're supported through and beyond. But there is much more that we want to do to make sure that it's a great place to work for people here. And build on the last 2 years worth of public and clinical engagement and the partnerships that we have in place. And the final 2 points are around some of the things we've already discussed today. We need to make sure that health inequalities and prevention are clear through our boroughs and our levels, and that we continue to make real impact in both of those areas. And we've agreed as a South West London, which I said earlier, that equality, inclusion, diversity would be a critical system priority as we go forward. So we wanted to anchor those in, anchor recovery in those objectives. If you move on to the next slide, when we began to talk about recovery, we refined our thinking into 4 phases, and at the moment we're in phase 2. So phase 1 was about the initial response to the incident. Phase 2 is around restarting. So as I've said, bringing non-COVID patients back into health and care services in the safest possible way. Phase 3, which we are beginning to build, are the plans that for the future. So what do we know that has happened through COVID that we want to keep, and what are the things that we might want to reshape as a result of what we've seen? And we did some work with each of the organisations and asked them for their reflections on COVID as a system, and we've given all of that feedback to each of the SROs for the programme, so they can build in the feedback that people gave on the really great things that have happened that we should keep, but also maybe some of the things that we should change as we move forward. And then phase 4, which is in our minds kind of November 21, is probably when there is a vaccine in place and we are working in a completely different way post-COVID, and we're delivering health services and social care services in a post-COVID world. So if we move to 58, this has moved and we've changed, but we have put in place now a range of programmes, and you've heard some of them mentioned already today, a range of programmes that will build our recovery plan. Each of them have an SRO, and those SROs are either executive directors around the table or clinical leads around the table, or their chief execs in organisations. But on my slide 5 and on your slide 58, you'll see the range of programmes that are going to come together to deliver the recovery and the strategic change going forward over the next couple of years. And importantly, the bottom line on that slide talks about the importance of making sure that we are looking at proactive population health management, reducing health inequalities, but we are doing and working with our boroughs in relation to that. So the real focus at South West London about the importance of boroughs is still anchored in recovery. So we are not moving to a pan South West London approach. We are anchoring everything we do in the work at borough level. And we can talk about any of those things. And what the slide also just identifies is the kind of areas that then are covered under each of those work programmes. And just in terms of where we are, so moving on to slide 59. So I've mentioned SROs. They are drafting work programmes at the moment. They are looking at timescales and key milestones, and also identifying the impacts and requirements of other programmes. So I can't remember if it's Pippa or Susan who talked about the matrix work, particularly around acute and community, etc. One of the ways that we're trying to address that is to look at the impacts that one programme has on another and the requirements that each programme has on each other, and put in place some formal and informal ways of making sure that those connections are strong. We're also finalising the attendees of the workstream and the members of the workstream, and making sure that where it's appropriate, that is multi-professional, it's place-based representation, etc. So the right people are on each of those groups so that we shape things together. An important piece of work that's happening over the next few weeks is looking at the resource plan. So what is required to ensure that our recovery plans are successful. And I've already mentioned considering the feedback we've already received. And then finally, as part of the work, SROs are looking at the requirements that London have set in terms of the tests and expectations that they have on recovery as well. And that's where we are in terms of the current work. There is a governance structure that has been put around. Moving on now to the next slide. So we have a South West London Recovery Board that is supported by a steering group that looks at issues of escalations and risk, etc., and tries to move things through. And It's now a clinical leadership group. We changed the wording of that yesterday, but a clinical leadership group, South West London chief execs, delivered through the programmes and working in partnership with elected official chairs, public and patients through the PPESC, and then the wider health and care partners at Borough. So recovery, embracing all of those things as we move forward. And then I think my final slide, before we move to any questions that you might have, just identifies the role and purpose of the Recovery Board and the members of it currently. But effectively, it is in place to consider and agree the recovery priorities, to scrutinise the quality and clinical impact of any of those changes, to recommend financial investment or disinvestment to relevant bodies. And importantly to say and to remind ourselves that the ICS, through which this work is being conducted, is not a statutory organisation. So the board will work with statutory organisations, statutory bodies on recovery and making sure that there are very strong connections to everything that happens, including things like public consultation and public conversations, should there be a requirement, and working with statutory organisations on that. So I won't go through the rest because it's there, but it gives you a flavour of the Recovery Board, who's on it, and how we're moving that forward. We are still in early days in terms of finalising plans. That will probably happen over the next 2 to 4 weeks, and we can certainly bring those back and share those with you if that would be helpful.
Well, thank you, Karen. Thank you, Karen. That's really helpful overview of the whole recovery approach. Are there any questions for Karen? I know it's not the first time people have seen the recovery architecture, so anything new that people wanted to ask? Dagmar and then Matthew.
Let me just unmute. Really helpful to have it all in one place, Karen. So as we said, the challenge is the knitting together of the place-based stuff and the Southwest London stuff, and iterating and really thinking which bits belong where. Yeah, and so I just wanted to draw your attention to 2 things. So as you're aware, so Ian Thomas had a meeting with all the DASs to really make sure that the senior people of the local boroughs, DCSs, also have a share in this. Yeah, and it was interesting. I hope you will have seen through. There's just a 1-page slide that reiterates the priorities for local authorities, and if you look at them, it's only 6 priorities. They really chime. So I think that's the good news, that we're all somehow on the same page. So the trick lies into actually translating that into how we make it stick on the ground. Yeah. And 2 particular things to raise to your attention is, first of all, in terms of COVID, living with COVID, as you are aware, local authorities are now leading on outbreak control. It is the realization that the pandemic has now fragmented and that it presents in clusters. It has a tendency, a propensity for some people spreading for quite unknown reasons extremely, and others not at all, and we don't understand quite why, but the phenomenon is clusters, and so it's locally, and we've just all published today or yesterday our outbreak control, and they require very, very close working of partners at a local level, because it is the detective work that is so important. So just drawing your attention to the need to engage with NHS as really important partners, and the way we're operationalizing it is through the BRFs. So they obviously have been a bit quiet when it was full command and control. But now in transition, they are borough-based, where we bring the partners together. So I wanted to raise that as an important theme to look out for. And the other thing is that we have got explicitly on these 6 priority lists is the financial recovery. because it's all fine to celebrate all the successes. I think loads and loads of real similarities, but the money doesn't add up. The income of local authorities dried up, and the bailouts we had are not commensurate with the income lost. So business rates, etc., the whole economic recovery is unknown. We still haven't got a clear strategy for long-term finance of social care. So finance is a real issue that sits like a black dot on our shoulders. And I just want to make sure that we all share that pain in order to really get the best for our residents jointly. So, and if you haven't seen the slide, the one-page slide, I think it would be good to wing it round and then really, in a way, reflect in the recovery plan, the reference to the local authority. Is that all right?
Karen, before you respond, hold those questions. Okay. Let me just take quick comment from Matthew and Bruno, and then that will be it. And then I'll get you to do a final response to those questions, comments, and then I'll need to move us on. So Matthew and then Bruno. And if we can't give answers to these, I think what we will do is commit to take them away as food for thought and to feedback outside the meeting.
So my point is really quick, Andrew. Obviously, I've been living this for a while. My point was going to be that this is still quite a dynamic situation. So even though these are relatively recently produced, if you look at slide 5 or page 58 of 112, that doesn't make it as clear as we now have it about diagnostics, for example, which has a specific programme around it because of the importance of capturing back waiting times on endoscopy and other key diagnostic tests. So I'm not making a clever point, I'm just saying it is a dynamic situation, and colleagues, the public, need to be aware that things are developing real time. So whenever you get something, be careful, because things might have shifted a little bit and we just need to keep everybody regularly updated. Andrew, is my point.
Thanks, Matthew. And then Bruno?
Yeah, my point was actually building on something that Dagmar was mentioning. In terms of mitigating the impact on health, the granularity of data on infections is going to be absolutely critical to partners in and to the NHS itself in trying to manage those. So are we convinced that we will have the granularity of data that's actually needed in near to real time to manage that, and also that in relation to influenza too? I mean, that's just an intermediate phase before the vaccine available.
Thanks, Bruno. So Karen, just final response to those questions, comments, and then I will move us on.
So in terms of Dagmar's one-pager, yes, please, Dagmar, that'd be really helpful, as would the outbreak control that you've put together. If you could share that as well, that would be really helpful. I think we share your concern about finances, and the health service will be as you know, as in a difficult place as local authorities will be, and James may want to say something around that. We are going to have to make sure that we continue to manage our money well. Matthew's right, the slides keep changing, so each time I'm happy to bring or send round, if it's helpful, a summary of the changes. We only had a recovery board yesterday, so they do move. And then in relation to Bruno and outbreaks, I think that question was probably more towards Dagmar, wasn't it, rather than me?
Yeah, so very good, Bruno, spot on. It's a challenge. You will have seen it in the news around Leicestershire. I can say in London, we have got very good relations with LCRC, which is Public Health England London, and we are receiving more granular data. And in fact, I've got a meeting tonight with Kevin Fenton to work out what we can actually publish on a regular basis so that you can see it as well, not just hidden away.
Thank you, Dagmar. That's really helpful. So I'm going to move us on. In terms of finance, James Murray, when we come to the finance report, you could perhaps very briefly say something about the finance work that's going on as part of recovery, but we can come back to that. I'm going to take us straight on now to the performance report, Jonathan. This is another item which is for information.
Yes, and I'm going to keep it brief, Andrew, given time. Obviously, it's another lens at which to look through COVID, really, in summarised in this report in a very tangible and quantifiable way. And you will see probably the most significant changes in some indicators that we have ever seen through the course of this period, as we would have expected. There are some clear strengths. So for people who did go to A&E, I know many people didn't want to, but for the people who did go to A&E, they actually received a very timely and responsive service, and there's a whole range of reasons for that. Some of that is down to lower number of referrals, but a lot of that is due to other changes like improved patient flow and suspension of the Care Act. And we also, on the good news front, managed to maintain a strong cancer performance against some of the measures we're all very familiar with, but also working with RM partners to ensure patients who needed urgent cancer surgery got that as quickly as they needed it. The challenges are also writ large in the plaque. Just to give a very high level summary, you can see the pressure doubled in aggregate in the month on 111. There were periods where it was much greater than that. You can also see the impact that we've been talking about and the urgency actually of restarting elective care, summarised in the deteriorating performance on elective and diagnostic standards, which I say are set out in detail. But given time, I'll probably leave it there, and happy to take any questions that people may have. I think you're still on mute, Andrew, I'm afraid.
Sorry, it's lagging, so I think I double clicked. You can hear me now. Thank you. That's really helpful. I'm assuming that people have had a chance to read the report, and therefore, thank you for just pulling out the highlights. I mean, I think some of the important issues you flag up are around, although cancer 2-week wait performance is good, a big part of that is because the number of referrals have dropped, and I know there's a huge piece of work going on pan Southwest London with Royal Marsden partners around cancer recovery and starting to try and get the right referrals coming back in, and likewise with elective care and the waiting times, there's a huge piece of work going on through the planned care programme to try and get that back on track and to prioritise the patients at highest risk to get them back into the system as quickly as possible. Shall I just come to you, Pippa, because you've got your hand up with a particular question for Jonathan.
Thank you. First of all, to say that QPOC have requested from Jonathan next time we meet, which is next month, a more detailed response on the elective and diagnostic recovery and what that looks like, just so you know we're following that up.
Pippa, can you just say what QPOC is? Because not everyone.
Quality Performance Oversight Committee. We've got a chair's report later. But my question for Jonathan is around 111. So we've heard earlier about how critical our whole digital response is, and it was really good to see in the report the improvements that are being made on the calls answered in the time frame and abandoned calls. So that was really good. However, we are still below. We've made a lot of progress, but we are still below some of the national targets, and I wondered, do you feel that we'll be able to sustain that improvement going forward?
So we have invested considerably to get to that level of performance, Pippa, in the incumbent provider of the service. And we are working very closely with colleagues in London to try and ensure that 111 delivers the best it can through this pandemic and any subsequent waves that we experience. I think against some metrics we actually do very well. So against clinical revalidation of patients before they're referred to a particular care destination, we do well in Southwest London in comparison with some parts of London. Against some other metrics we do less well, like booking directly into urgent treatment centres. So it is a mixed bag. we're continuing to do all we can with Vocare as an independent provider of these services to sustain it. There are daily and weekly conversations to try and sustain performance, and we are making investment where necessary. People will be aware that a text message has been shared with all patients across London, and we've seen a subsequent increase in demand of around 10% resulting from that, and we've met that demand and managed to maintain performance over the last week. So I can't give an absolute guarantee is the short answer, Pippa, given the range of challenges we face, but do I feel we're doing all the right things to maintain performance? Then I think we are, and Matthew and I are chairing a weekly urgent emergency care restoration board in South West London, and one of the big topics of that is what more we can do with Vocare, CellDoc and the wider system to deliver. Hopefully that's
really
a helpful answer.
That is very helpful. Thank you.
Thanks, Jonathan. And then, sorry, Susan, I think I missed your comment. You were asking to come in, but that might have been in relation to recovery, not to this. Is that right?
No, it was to do with the performance report, if that's all
okay.
right.
So why don't I take a comment question from you, and then from David, and then I'll come back to Jonathan to wrap up this particular item.
It's really a follow-on from Pippa's point, really, because there were some legacy issues and issues around compliance that have obviously been put to one side because of the result of the pandemic. And I just wondered, in taking them forward, will the Workstreams try to absorb those issues as well in terms of reshaping services? I'm thinking particularly around dementia and mental health, things that we might have been working on that have been put into abeyance, but now need to be included as part of our return to some sort of delivery. Is that the route that we're going to be taking? That's what I was trying to find out.
Thanks, Susan. So hold your response to that, Jonathan. Let's hear from David, and then I'll let you respond to both.
Yeah, my comment and question, Jonathan, is around the need for trajectories as we go forward, because clearly we've got, because of COVID, obviously activity has dropped off. So we're reporting against a slightly, in that sense, a slightly false position, really. But as we go forward, I think we do need to be clear when we're monitoring, what are we monitoring against? So what are we trying to deliver? I know it's going to be difficult to do that, but we've got to somehow reset what our trajectories are going forward.
So Jonathan, back to you.
Okay, so I think on Susan's point, which I think, if I interpreted it correctly, was largely around how are we going to incorporate the things that we need to do and need to retain and business as usual going forward. Then I think that's an issue that each of the recovery programme groups is going to need to reflect on, because there are some work programmes that we will need to refocus through the course of this. And there were others where there will remain an absolute priority. So, for example, diabetes would be a case in point. That is something where, given the number and relationship to COVID, we probably need to be redoubling our efforts. So I think there is something about thinking it through programme by programme. Maybe I've interpreted that question, Susan, more broadly than performance, but that's the way I perceive it. To David's point about trajectories, well, providers have started, it was in the phase 2 letter from Simon Stevens, started to be asking to report on a range of information again. And we're starting, and a lot of that is on a weekly basis. So we're starting to get that and be able to collate it and be clear about what the position is. There is a performance and quality work stream that Pippa's involved with, and Daniel Elkerlees, the Chief Executive of Epsom St Helier, and I also involved in, and that's really mapping through how we get from where we are now, including working out what the key metrics are that we need to be measuring from both at this point in time and going forward need to be, and what the trajectories that will subsequently fall out of that need to be. So we are on the case, but we need to work out what are the key things that we want to measure, both to help manage any subsequent spike or any outbreak in the system, as well as the key things that we would have historically measured going forward. So hopefully, David, that covers a lot of what you wanted to address.
And Jonathan, for the future, what might be helpful is for the CCG board to I know Pippa's involved in the group, but the work that the Quality and Performance Recovery stream does, Pan South West London, is particularly pertinent to our very function as a CCG, and I think we probably will want to bring something back to a future meeting when some of that work at South West London has been done, so that we're cited on that. I think so. I'll let you and Pippa work that through outside the meeting about what and when we bring back, but I think we'll probably want to have a view on that.
That's great. Very happy to do that.
Okay. Right, look, I'm going to move us on because I'm not doing particularly well in managing us through the agenda on time. So I'm going to whisk us straight through to the finance report. And this is for information, James. And you're also going to quickly say something about the work that's being done Pan South West London on financial recovery.
Yeah, I will do. I'll try and be as swift as possible. So, so this year, as we go into a new CCG, was always going to be different, and obviously pandemic has made it even more different than we thought. So as people are aware from our previous conversations, effectively there's been a bit of a financial reset in terms of we aren't working in the way that we used to work. Allocations were reset, direct block payments to trusts were set nationally, and that's the system we're working at. So and that lasts till the end of July. So at the moment, the report that you've got in front of you really shows how we've spent against that revised sort of allocation that we received. And from a CCG perspective, we've spent additional expenditure over and above what was set nationally of 16.7 million. 12.7 million of that was related directly to a COVID cost expenditure, and 4 million is other sort of underlying things that we're just working through at the moment. That gets submitted to NHSE, and it has done this month. And the intention is that we will get an additional allocation to cover that spend, and that's just being validated with nationally now with NHSE. We've been through the London process. We'll carry on doing that till month 4. And then there'll be some new guidance which I'll talk about in the meantime. Just to reassure the board that we put in a revised governance process, which David Smith and Paul Gallagher review fortnightly with myself and Sarah around the expenditure on COVID, and that's all gone through a process in line with SFIs. And we've run that past the internal auditors as well. So there has been some additional governance in place to make sure we've got control over and above to sort of support the sort of accelerated working that people have been talking about. So that's where we're up to on month 2. In terms of what happens after month 4, the answer is I think we're getting directions of travel, but we don't actually know the real guidance at the moment. So I think it will change in terms of as a system overall. We will probably revert back to having a budget to work within with no sort of retrospective top-ups. We're expecting that guidance. We're 1st of July now, aren't we? So we're expecting that guidance and the numbers for that this month ahead of that system. And we've been talking through with Finance Committee, which I'm sure David will mention when he does his committee update. We were talking about this yesterday, just about how we're going to manage that. I think the thing we need to be ready for is it's not going to go straight back to the old system. So we will need to work collectively together as a system in a different way, completely to how we've worked before for the remainder of this year, to make sure that we can get the resources in the right place and we're supporting the recovery in the way that we need to, and we're not holding things back, but equally recognising that we are going to have a financial envelope to work within. Just picking up on the point that Dagmar made there around the local authority side, clearly we need a holistic way forward going with local authorities and NHS. And I know when I was on an STP leaders call for Sarah last week, that was discussed. Again, I haven't got any detail on that. Clearly local authorities have got their own challenges outside of just trying to manage the social care impact of COVID, and we will need to work closely with our local authority colleagues to make sure that we understand the whole system position, not just the health system, because you can't look at the two independently. I think there might, again picking up on what Lucy says, there might be some changes in the way that some of that might work going forward, particularly around some of the discharge stuff. But again, until we get the detail, I can't really say. Again, we will take that through the next finance committee, and we'll hopefully we will be in a much better position to give the board a more fuller picture of how it all looks moving forward. I've got two other minor points, and I'll wait to take questions just so people are aware. I think Sarah mentioned about the accounts, so those all got submitted last week finally, all with the requisite approval, and I'm pleased to say that also South West London as a whole, with all the providers, that all got signed off, and we have balanced as a system overall for South West London, so that's an achievement for everybody. And if people remember, that did enable us to get access to some additional money for Sutton, and to make sure that George's kept their FRF. And the other thing just to mention is that the mental health investment standards will be published next week, so so they'll go on the website. And that's it from me, so I'll take any questions from there, Andrew.
Thank you, James. That's really helpful. Let me just turn to David as chair of Finance Committee. I'm sure you probably got something to add.
Yeah, really just to add to that, and just to assure the board. So the Finance Committee is meeting. We're meeting monthly. We had a meeting yesterday, and we went through the detail that underlies this, because as you can appreciate, you know, as a result of COVID and the way we're now having to handle the money, the level of complexity is levels that we've never worked in this way before. So it is incredibly complex. So what we have said as a committee, that at our next meeting in about 3 or 4 weeks time, we're going to spend the first part really doing much more of a sort of as a training and briefing session, so all members fully understand what these numbers mean. So I just wanted to particularly say that. We have, again, yesterday we went through looking at the month 2 position for the CCG and also for the wider system, and that we've done that. But as I say, I think as we go forward, and particularly when we get hopefully the guidance for the remainder of the year, then I think we'll be in a better position to look at it, because I think as James would have said, that when we look at the budget, and one of the slides, it's the slide on page 89, when we talk about the total budget there, that's essentially the total budget for 4 months. It's not the full year budget, and we've never worked in that way before. So I think, you know, all credit to James and his colleagues, because, you know, for sitting on top of what is an enormously complex and moving position, and explaining it really in ways that hopefully most of us can understand. So thank you for that. But as I say, I just wanted the board to note that.
Thanks, David. That's really helpful. So are there any other questions for James, or any other comments that people want to make around that? Is that a no? Okay. James, you did such a great job of explaining it that you've covered all the questions people thought they might want to ask. So thank you for that. I will move us straight on to the committee updates then, because we've got an update from the Quality Performance Oversight Committee, QPOC, and there's quite a bit of information in that report. So Pippa, shall I just come to you to just pull out any key issues you want to bring to our attention?
Okay, thank you very much. So some of this we've covered off today, so I won't go into too much detail. The first thing I wanted to highlight was the terms of reference. So we are keeping these under review, because obviously with recovery work and various other things that are going on, it may potentially have an impact on the committee and the work that it's doing. But we were specifically looking at membership last time. We had a quite detailed conversation about making sure that Healthwatch were actively involved at our place level committees. We felt that was really, really important. And we've heard today about all the work that's going on there, and the shaping of services that that happens. And I've joined Susan's group so that we can make sure that we are hearing the patient's experience of services across South West London. So that's where we've got to with that at the moment. The South West London performance report, Jonathan's given you an update on. The only thing I would add to that is that, in answer to your question, Andrew, we had a discussion at QPOC about needing to ensure the recovery, quality and performance work stream is linked in with the QPOC piece of work. We felt there was very much an overlap there. So as Jonathan and I sit on both, we will make sure that that happens going forward. Through our quality report, I reported last time that we would look at safeguarding, and indeed we did do that. We received some data and we had assurance around the work that was ongoing around that. And next month we've got a whole detailed report specifically on safeguarding across South West London. And the other thing on the quality reports, I'm on page 92 now, that's worth highlighting again, it's this borough, the importance of boroughs in place. We had a discussion about how critical it was that the place and borough systems are identifying and the learning that needs to be picked up at that level, and at South West London, so we don't duplicate. We will pick up themes and trends across South West London. I think that's worth saying. We received a report on some of our most vulnerable people within South West London, specifically learning disability and those with a mental health diagnosis. And we gained assurance on the really good work that's been put in place to both risk assess and identify those people and put support packages in place for those who are on the shielded patient lists. So that was a detailed report that we received. The risk registers. So we had a look at the quality risk registers. Now, quite a lot of work was done on this at boroughs before we became one CCG in April. And I know Ben will agree with this. It is still very much work in progress, and some boroughs have made further progress with this than others. So there is some further work to do. What we want to be able to do is to pull out the key quality risks across the CCG, and those are the ones we'll look at the QPOC going forward. The service change review group, Andrew, you alluded to this in your report, so I probably won't go into it at the beginning in your chair's report, but just to say we did have a detailed report on that. And the final thing, we had a even more detailed report from Lucy specifically on care homes. So you had a sort of an overview here, but a really, really good detailed report, both across South West London and at borough level, just so we could get assurance on how we were supporting that group of our population. And finally, it's important that the governing body note that we have approved a number of policies, which you can see at the end of the report, which will support our communities and our staff across the CCG.
Thank you very much, Pippa. That's really, really helpful. Can I just take then quick questions from Liz and Bruno, one after the other, and then we can respond to that, and then I'll move us on to the Remuneration Committee.
Thanks, Andrew. Just to say, Pippa, that we don't feel as Health Watchers we have got clarity yet on the place committees. So if we could take that up with you by correspondence outside the meeting, that would be helpful. Thanks.
Okay, well, we've asked for assurance on that. So I think that's being looked at each of those areas. So I agree with you. It's a really important point. Yeah.
Could I just ask, have you had assurances?
No, we asked for it last time, and we also recognised it will be different in each area, but Health Watch need to be involved locally. So that's what we've asked for, and we'll get a report back in August at our next meeting.
Bruno?
Yeah, my point paralleled that in relation to the voluntary and community sector, because they have a role both in mitigating some of the risks to quality which there are, and also in accessing patient quality information from Black and minority ethnic communities and others who are seen as hard to reach, because they work with those all of the time. So it's equally important the voluntary sector is involved at place level. I know there was work which had commenced before the epidemic through the integrated care system and also locally, but that really needs to be picked up on. We do really need assurance around that.
Okay.
Yeah. So I mean, there is work to develop our approach for the local committees, which haven't been given the full range of delegation and things to do that we had anticipated when we set up the CCG, and that's been because of the focus on the response to COVID and the change in the way we work. But we are reinstituting committees, and actually we have had a discussion about using our next governing body seminar to think about how we develop that approach. Sarah, you've got your hand up. I think you're just going to give an answer to that.
Yeah, no, I think we need to pick it up in P pairs, exactly how we engage with everyone. Place committees obviously are not just about the CCG, they are about our partners as well. They are about, you know, integrated systems across the whole piece. And I know that there is a commitment in each of the boroughs to involve Healthwatch and others. So I think let's take that outside, and I know that Charlotte will pick that up with P pairs. Is that okay?
Thanks, Sarah. That's really helpful. So let's go on then to the Remuneration Committee. David, there was something specific you wanted to bring to our attention.
Yes, so thank you. So a reminder to the board. So the Remuneration Committee is a committee of the full board, and normally what we would be doing is having our deliberations, and then we'd bring recommendations to the full board for approval. We've had 2 meetings, and as noted in the paper, on one in particular, and that was the salary of the chief nurse, where there was we effectively agreed to increase that salary. We had to take chairman's action, and Andrew Murray, as the chair, agreed chairman's action on that. As I say, normally we would bring that to the full board, but we took chairman's action because we needed to go out to recruitment, as we hadn't been able to recruit first time round. So the board need to retrospectively approve that. We've also approved a very small amendment to very senior managers' remuneration, and that's followed a national pay increase. It's a very minor change. And then the third area is there's a very small number now of redundancy payments that we're having to approve, and that's as a result of the Moving Together programme, as a result of bringing the 6 CCGs together. So again, we're working those through. So it's particularly around just to acknowledge that we've made those recommendations to the board for the board to approve those. Thank you.
Thanks, David. And yes, you're right. I did take chairman's action around the first 2. So I guess it's now just hearing from the board. Are there any objections to those recommendations, or are we happy with them as set out in the Remuneration Committee report? Everyone okay with that? Yes. Good. So that's agreed. No objections. Excellent. Thank you, David. Right, let me take us on then. We've got no updates from the other committees today.
Andrew, sorry, it's Paul. I do have a brief little update for audit. Although it says no update, there have actually been 2 meetings since we last met. So okay. I'll promise I'll do it in 60 seconds if that's okay.
That's fine.
So just to update the governing body, the Audit Committee met at the end of May to approve the annual accounts, and just very, very briefly to confirm, as I think James and Sarah said earlier, all financial targets were met. There were no material adjustments required, no material changes needed to the annual reports or the accounts, and we had an unqualified audit report. And further to what James said, we submitted the accounts, I think it was the 25th of June, and so that's all been completed now, and again, you know, thank you to everybody involved in that in difficult circumstances. It was all done on time and you know, very high standard. And then the second meeting we had in mid-June, that was more the BAU report, BAU committee. I think the 3 key things from there was just an update on the fraud and bribery policy, which we approved. And also an update on the internal audit plan for this year, which is just to sort of focus on some of the emphasis we want to place around, you know, the post-COVID governance. And then I think the final point, and David raised this as well, we approved the financial governance around COVID as well. So as David mentioned, you know, how we monitor that, the tender waivers that we've had to, you know, produce, that's all been understood. It was in the presence of the internal audit and the external auditors too. So that's something we just as a committee and as a board need to continue to watch going forward. That's pretty much it, Andrew. Thank you.
Thanks, Paul. That's really helpful. Any questions for Paul then relating to the business of the audit committee? No, thanks. That was a helpful update. So I'm going to take us on to the next item on the agenda, which is the Memorandum of Understanding between the CCG and Croydon Health Services, and this is for approval. So Matthew, do you want to, I'm assuming people have read the paper, so do you want to just talk to it and flesh out the issues for us?
Of course, Andrew, and I'll say, assume people have read it. We've had a MOU between CHS, the Trust, and Croydon CCG last year. It sets out the way that we are working together as an integrated place. Obviously, that's needed to change with the enactment of South West London CCG, and so this document, in essence, refreshes the MOU and changes it from Croydon CCG to South West London CCG. There's not massive substantial changes in what the content of it is. It's a memorandum of understanding. It's obviously important for us to have some governance around how we're working in place. Ben Luscombe has done what Ben does brilliantly, which is make sure that this is appropriate from a governance perspective. We've talked about it locally here in Croydon and are very supportive of it. I have shared it obviously in preparation for today with Sarah too. So if colleagues are content, then it would be approved and we'd start having this as a formal piece between South West London CCG and CHS. What it doesn't do, obviously, is sign people up to you know, unlimited changes that we don't have to check or agree with the relevant bodies. But it is important for us to have some formality around what we're doing, and that's the intent, and to make it appropriate for South West London terms now as opposed to Croydon terms. And obviously, that's been active since the 1st of April, but with COVID and the timing of this board, this is the first time we've had a chance to come back to this group.
Thanks, Matthew. So, I mean, as I understand it, it's basically continuing the existing arrangements, but reflecting the change in the CCG structure, and it's going to continue for another year, and it allows you to have joint roles across the CCG and Croydon Health Services.
Correct.
Yeah. Okay. Agnella, I take it you're very supportive of this with your thumbs up, and I know you've been instrumental in making sure this happens.
So yes, we're all happy with it. Thanks.
Okay. So, any questions from other members of the board before I ask for a decision around this? Any questions, concerns? No. I know people have had a chance to digest this, and it's not a new arrangement. So I'm going to ask then for us formally to approve it. Is everyone happy to formally approve that? That's a yes. No dissent. Everyone happy? Excellent. Good. So that is approved. Now, we haven't had any questions from the public that have come in before the deadline. We have had one question that came in after the deadline we'd set. So I'm proposing that we just deal with that outside the meeting. It was a specific question relating to Queen Mary's Hospital, Roehampton, and I know James Blythe is going has already started to prepare a response to that. Can I ask then if there's any other business? Ben, Yvonne, I've not been notified of any.
Nothing that I'm aware of, Andrew.
No, okay. In which case then I will bring the meeting formally to a close, and thank you everyone for your time.
Thanks, Andrew.
Thank you.
Thanks, Andrew.
Thank you,
and
Andrew.
bye.
Bye.